designed to others, put them in universities, be PSUT, students that know how to design chips and silicon. And there's a couple of labs that are still there. And one of this whole thing is the importance of the Jordanian diaspora, America in specific. طبعا worldwide is very important, but and myself with a few colleagues, including Dr. Isa Batarse, who is the head of the engineering school now in Central Florida University, Dr. Wissam Al-Rabadi, who is our Minister of Planning in Urdun right now, Dr. Rami Rihani, who is not with us today, and few others that really went back and forth a lot and were educated in the States, felt the need of creating Connect.JO. And Connect.JO basically is an organization of professional Jordanians. The initial plan was to do it worldwide, but then we realized that's very hard. So we focus on the US. We were backed up by the USAID Economic Conformance Program Urdun. And really it was kicked off after His Majesty King Abdullah's visit to UC Berkeley back in 2014. We had private audience with His Majesty, and he encouraged us to go ahead and launch this. Since then, we've done quite a few seminars, quite a few meetups. We had some conferences in Silicon Valley with startups and technology. We had some conferences in the embassy in DC, focusing on students that come from Jordan to the US and how we could mobilize and activate them. And really the whole objective of Connect.JO is to connect professional Jordanians together across the United States. Today we have around 65 active members. It's not very big, and we're actually reactivating the network as much as possible. The latest event we did was in February, where His Highness Crown Prince Hussein came and did a keynote address to a group here called Tech Wadi, which is a technology association for the Middle East and North Africa. He did a phenomenal keynote speech, and we managed to have him meet with about 50 or 60 of the Jordanian diaspora in the Bay Area. And we're working with his office right now actually to reactivate Connect.JO and get it going and see how we could, first and foremost, help each other in the States. But then secondly, how we can also help Jordan in terms of brain gain, in terms of giving back in intellectual property, giving back in terms of investment, giving back in terms of internship and hosting people from Jordan. Our activities include scholarships. We've done a couple, and we're working on about 4 or 5 that we hopefully will launch this year. We do internships. We hosted many Jordanians that come, whether it's in the field of renewable energy or in the field of healthcare. And that's something that we're going to activate more and more. We work with many partners. The Crown Prince Foundation is one. USAID is another. We work with the American Chamber of Commerce. And now what we're doing is actually trying to put the Jordanian American associations in order for us to really leverage the power of the many Jordanians. And there's many phenomenal Jordanians. All Jordanians are phenomenal. Getting them together. And the effort that we're doing right now is a fundraiser for COVID-19 Urdun. So far, we raised roughly $40,000. Our goal is $100,000. And that's all coming through the Jordanian diaspora. Is going to go to us for this initiative, which is Faza Shabab and Takiyatum Ali in Urdun. So that's kind of a brief of where we are. I'm really happy to be here. I'd love to answer any questions. And our website is Connect.JO. It's basically Connect.JO. And you could look us up online. It was good enough, Hadi.
Thank you, Zaid. FYI, this session is being recorded to make it available for those who cannot make this time. So if you don't consent, you can watch this later, but I hope all of you stay. Now I would like to introduce my friend, my colleague, and the president of JAADC, Melissa Khorma, who will moderate this session. She will ask Dr. Halazoun a few questions. And once she is done, we will have our Q&A session. With that, Melissa, on to you.
Thank you, Fadi. Thank you all for joining us this afternoon on the East Coast and I guess morning on the West Coast and maybe later evening from Jordan and the Middle East. It's a true pleasure for me to moderate this session today with Dr. Hadi Halazun. Hadi wrote a very passionate letter to the IC unit that he was in charge of a few weeks ago that went viral because of the passion he displayed, and I think that just the rawness and the honesty that he communicated in the letter. And since then, he's been doing a lot of media, and I thought this would be a wonderful opportunity, given that Hadi is one of our own members of the diaspora here in the US, to just talk to us about what it's like to be on the front line. So this is sort of a day in the life of, Dr. Hadi Halazoun, who is one of the many Jordanian, but also one of the many Arab American doctors in the United States at the front line right now. So thank you so much, Hadi, for doing this. And welcome. So I think my first question is a very basic one. You are at the front lines of what you called a COVID war. We're all quarantining ourselves, trying to parse through the media and different headlines to figure out what's happening. There's a lot of uncertainty, but you're really, you're at the heart of this storm. So what is it like to be on the front lines? What is it like to be at the hospital every day?
First of all, thank you for having me, Connect.JO, Fadi, Zaid, and you, Marissa. It's an honor to be invited and to speak to everyone, even though it's on Zoom. That's, I guess, to 2020 for us. And again, thank you so much for having me. So what it's like on the front line. So when they're called the front lines, first of all, because as you imply, it is similar to a war, and more so in the beginning of it, which is when the letter you're referring to, when I wrote it back in early April, late March. And the similarities for war, not that I've actually lived through a war, but they come from the fact that really no one knew what they were doing, to be quite frank. In the ICU in the hospital generally tends to be the most controlled part of the hospital. You know what's coming in, you know who's going out, everything's under very much a lot of control. It's minute to minute, hour to hour control. And by sheer volume of the number of patients we were getting, one after the other, and literally within 20 to 30 minutes, you get 2 or 3 patients, all intubated, all very sick. And if we take back to where we were back in March and April, we were just employing things that we knew in general medicine and ICU medicine to treat these people. And we had no clue how COVID would be different than anything else we've managed. So the challenge wasn't only in it being different, but the sheer volume of patients that we got and the frequency by which they came felt as if we were just being bombarded. And then to further the analogy and with sort of the description of the front line with war is that there was a very strong feeling that everyone was in it together. Medicine tends to be siloed. The cardiologists are here, the pulmonologists are here, the kidney doctors are here, the nurses are there. Everyone's in a different part in an own little world, and suddenly everyone just came together, and everyone put their ego aside, and it's very beautiful to see. The lowest person on the totem pole, between the medical student to the lowest, to the intern, to the most senior lung person, any idea would have been something that we would have taken seriously. It's because we didn't know what we were doing. And I hate saying that to the lay public because it's scary. What the doctors didn't know what they were doing, but that's quite frankly the truth. Is that it was so new to all of us, and it was so hectic that we were just grasping at whatever we can to help these guys, help the patients that are coming in. And it was emotionally very, very tough as well because people started dying very quickly. And so I'm not sure that's what you were asking me, but that's where the analogy of war comes in. There's a lot of death, a lot of uncertainty, a lot of camaraderie, and everyone's staying at home and watching and waiting for this to end, even from the beginning. So it really felt that we were in a battle of some sorts.
Yeah, and like you said, you know, we're all navigating uncertainty because we're looking at the medical community to give us some answers, but then nobody seems to have answers. And every time there's a headline about a potential vaccine coming or a potential cure, you know, there's a tad of optimism. How does that play out in the setting that you're in?
It's very tough, and I'll give you the best example of that is the medicine which everyone knows now, remdesivir. Everyone's heard of remdesivir, and if you haven't heard of remdesivir, you're really doing a good job at not watching the news. So that's my first recommendation: do not watch the news, because there's really nothing good that's going to come out. But I'll give you the example of remdesivir. Remdesivir is a medication that initially, in the beginnings of the pandemic, was thought to work, but it was still under study. From prior sort of smaller studies, maybe that there may have been a benefit. And as you guys probably all know, at some point they announced that remdesivir works against coronavirus, and all of a sudden the markets are doing great. Everyone's in a better mood. Remdesivir is going to save the day. But what does remdesivir do? Remdesivir only reduces your hospitalization from 15 days to 11 days in the sickest of patients who are intubated. So for us on the front lines, we're like, why is everyone so cheerful and gung-ho behind remdesivir, and where we're seeing something completely different? And that is the biggest challenge. I'm using that as one example, that the reality which we're facing is so different than what you're seeing in the media. And the thing is, you know, not to get political about it, but the media either makes it more this crazy hype, or tends to be, no, it's not a big deal kind of. And it depends on the political views of it. And I haven't seen much of true representation in the media of what we are experiencing. It's very hard to get that, because hospitals don't allow the media into the hospital areas. And so, to answer your question, how do we deal with it? I personally choose to ignore it. I stopped watching the news a long time ago, because it's day to day. It's a 24-hour news cycle. It increases your anxiety, drops your anxiety, and I would recommend for people just to limit the amount of news they watch, because for us in the front lines, it's just mind-blowing how different the reality is than what is being described. So, and it tends to lower our morale, to be quite honest with you, because you sort of want to scream the truth and say that's not what's really happening. And that's why I try to go on the media at least and try to share our story, our perspective from it.
And you hit something that was sort of my next question, which is, with all of this commotion happening, even if you insulate yourself from the media, and it's good that you do, you're in charge of an ICU unit. And, you know, there will be waves of high and low anxiety, high and low morale. How do you, in a position of authority, basically try to manage everybody's emotions and everybody's anxiety? Plus, you have to do that for yourself as well, right? There's, you know, caring for your people, but also self-care, which is essential as you move forward.
So the ICU is a strange place, because once you're in the ICU, there's almost an isolation from the rest of the world. I'm trying to recall the number of times we've talked about anything in the news while we're rounding or while we're seeing the patients. So the anxieties we try to discuss and try to deal with are not related to the anxieties of the public. What we are worried about, and actually we're just listening over, my office is next to an office of physician assistants. What we try to, and I'll tell you about what I'm referring to, what we try to do is manage anxieties that are specific to taking care of these patients, which are the expertise or lack thereof of certain people who have been called to the front line. You know, that creates a lot of anxiety. Just for sake of example, you know, we've let's say you have a dermatologist coming to work in the ICU. That's not their expertise, but we needed the manpower to do so. That creates anxiety for that person. But generally, the largest amount of anxiety comes from partly not knowing what to do, sort of not being very familiar, but mostly comes from the fact that these people are separated from their families. You're taking care of people, and then you have to take the responsibility of describing to a family member over the phone what's going on with that person. And you can do that once, you can do that twice, but it's been going on for 2 months now. And the people who have to do it are really hurting. It's very painful to talk to these families. It's very painful for the families to be on the receiving end. And conversation after conversation can bear heavy on the soul of people doing this. And not to mention, this is a very protracted disease when it comes to the ICU. People are in the ICU for 20 days, 30 days, and they don't get better suddenly. They don't get worse suddenly. It's just sort of almost the same conversation over and over again. People wanting glimmers of hope, and you're not able to deliver. And that part supersedes any amount of anxiety, any amount of, I don't want to say depression, but any amount of, let's just keep it at anxiety for the people who are on the front line. And that's what that's my goal as a person who's in charge to deal with. I have to make sure that everyone is doing okay. Everyone is just that, doing okay. And I think what I try to do is create a very transparent line of communication between me and them, that sometimes I'm not okay. Sometimes I have to go to my office and take a moment or even cry. It's tough. And for them to see that makes me more accessible. And so I don't hide that from them. We're all vulnerable here. And I think that's probably the best way for me to manage their and our anxieties. But just to emphasize the point, we rarely ever talk about what's going on in the media while we're not because there's a rule or anything. It's just
there's no time.
We're too busy,
right,
doing what actually matters.
Yeah, it's focusing on the work at the center of all of this, right? So you said sometimes you just go back to your office and take a moment. What else do you do for self-care over the weekend?
That's the problem that everyone is facing on this Zoom call. We can't. There's no balance in the in our lives. People in the beginnings of this are like, oh, you're going to go to the front lines, you're going to put yourself at risk. I'd much rather go to work and into a hospital and sit at home all day and wait and do work from home. Work from home to me sounds like torture. No offense to everyone who's working from home, but it sounds horrible. And I'm glad that my job doesn't require me to do so. In that way, I'm very, very lucky that I have a semblance of balance. I've had unhealthy ways of coping, and I've had healthy ways of coping. The unhealthy ways is I'll speak for myself. I drink a little bit more than I would otherwise, quite honestly. And, it is what it is. I think everyone under quarantine is maybe doing the same. But I also bought a Peloton, so that's also a good thing. Not a plug for Peloton, but I love it. It's really a really good tool for exercise in places where the weather wasn't nice enough to go out running. Amman, obviously, and San Francisco has much better weather than New York does.
Than the East Coast.
So that exercise and a little bit of drinking, sadly, is what I do to deal with this.
Whatever it takes. So one thing that keeps coming up in conversations with friends and family is what we talked about before, just looking for that one piece of good news. And it's the cliche is always that in every crisis there are opportunities, there are silver linings. It's really hard to sift through all of what's going on right now to find that. But if you were to identify one silver lining, what would that be?
Personally, or for everyone else?
Whichever way you want to answer.
So personally, I think it's brought me closer to those people who are further away, including my parents and my family and my friends in Amman. I feel even though like 40% of the conversation is about COVID and all that on our Zoom calls, it's still, I'm talking to people who mean a lot to me whereas I wouldn't have. I talk to my parents 4 or 5 times a week now. Prior to this, it was about once a week, you know. So the silver lining, it's weirdly brought us all together. And also it's the first thing in our lifetime, whoever's on this, that's brought everybody around the world is facing the same thing. You know, whether you're sitting in Amman, sitting in London, San Francisco, DC, New York, you're sitting at home and you're waiting and you're watching and you're working from home and you're feeling almost exactly the same way. You don't need to tell me how you feel in Amman versus in New York, because we feel the same way. Or London. And I think that is, at least for me personally, I feel much more in touch with home and much more in touch with my friends all over the world. So that is the silver lining of all this, if I understood your question correctly.
Yeah, absolutely. And this is the sense of community is what all of us are feeling. I think most of us have the same experience in terms of connecting with family and friends and colleagues even. You know, happy hours online, which didn't exist offline, right?
Yeah.
So, you know, there's a need to sort of come together, and collaborative efforts at work are also sort of on the uptick, which is always a positive thing.
And you can always end a Zoom call by leaving. There's no awkward moment.
Right. There's no awkward, you don't have to say bye to everybody.
Yeah,
That's
you
right.
don't have to say bye. The infinite goodbyes of the Arab culture are not present with the Zoom.
Right, exactly. But if we were to just hone in a little bit on, and this is, you know, far-fetched question to answer because we don't know, but just looking broadly and maybe in the US context in particular at the health system and how this crisis is, you know, probably the learning curve is so steep because there's constant learning, right? Is there time to debrief so that we know what lessons learned we can then hopefully in the long term apply and be able to avert similar crises or be more ready for the future?
Well, I think your question is an excellent question, but it's simply answered with Marissa, it's America. They don't, to a lot of Americans, they're dealing with this excellently. This is the best, you know, you're the closest person to the White House on the Zoom call, and what comes out of there sets the tone for the rest of the country, in that a lot of people believe that America is dealing with this in the best way possible, and it's not. And we all know this, that it's not. You know, the numbers don't lie. The number of deaths, per capita, the spread, the bickering, the politics, all of this, you can tell sadly that there's not a lot that's going to be learned from this on a national level. But on a state level and on a micro level, I think hospitals are learning, medical associations are learning, cities are learning how to deal with this. And so I think what you're going to see is that places who have dealt with this, such as New York, and other urban hubs, may develop ways to deal with the next pandemic in ways that doesn't require the federal government to step in, which is unfortunate because the virus itself doesn't respect state lines, and so you do need a federal sort of response team, which is headed by the CDC. Now, just to go back and speak about the medical system itself, the American medical system is broken even prior to this, and this just, I think, accelerated our realization how broken it is on the fact that, you know, we couldn't absorb the shock in the way that we should have without upending the entire hospital. Our hospital stopped doing elective procedures, seeing outpatients since the beginning, like mid to late March. And we had to do that in order to accommodate the number of patients. We had to take over every ICU, we took over every operating room, we took over 2 or 3 other floors to accommodate this. So the whole hospital system had to stop operating just for these patients. Now, could they have done it better? I'm not sure, but it also speaks to a lot of the unnecessary stuff that is being done in the hospital. You know, there's a lot of things that are unnecessary testing, unnecessary admissions, that, you know, you would think if all these patients who are not coming in now where are they? You know, we still don't know the answer. We're all thinking there's going to be a second wave of all the sick patients who haven't come in because they're afraid of COVID or because the hospital's closed. We haven't seen that yet. We were all sitting and waiting to see of people who've had strokes, heart attacks, all these things that, that they just didn't come to the hospital yet, but we still haven't seen that. And so I think what should come out of this and what hopefully can come out of this is a self-reflection from the medical community to sort of deem what is actually necessary in what we're doing. All these tests that we've been doing, all this procedure that we're doing, what's actually necessary, and in changing that or limiting to what is necessary, you can reduce costs and you can reduce the healthcare bill that everyone's sort of worried about. The problem is this requires political leadership also, and that's what's lacking. There's a gap and a vacuum in political leadership, and I don't think, I sadly, not to be pessimistic, I don't think America is going to learn anything from any of this on a national level, sadly.
Well, I hope you're wrong with that, because especially if at least on the more micro level, there are lessons learned. I mean, you mentioned that there are all these unnecessary visits. We're all, we all have telehealth calls now with our doctors for things that we would have gone for happily, to clinics.
Not to interrupt you, but I was going to say the flip side of that is one of the good things that's going to come out of this is the acceleration of telehealth. Telehealth now is in the forefront, and it just requires that Medicare and Medicaid and all the insurance pay a similar amount for a visit in person versus telehealth. It has to be that way in order for it to be viable, because with clinics, the way they are set up, we don't need to get into Medicare billing, but you need to see a large volume of patients to pay for what you want, so the services that you run. And, you can't pay half because it's a televisit. It won't work that way. But for sure, telehealth is going to be, has accelerated as a result of this.
Yeah, that was going to be actually my question. Like, how do you see the future of telehealth? But clearly we're moving in that direction.
In-home, like wearables, all this technology is going to be has been accelerated by this. The thing is, you still do need people to come in. I envision home testing services, as in why bring you to the hospital, bring the test to you, like an echocardiogram, blood draws, all of this stuff.
Yeah.
If people are still worried about going out and interacting with the medical system, that may be a solution. But in the United States, I think that tends to be taken over by the private sector and as a response to the broken public sector. So and I think that's probably better because they tend to be more efficient.
Yeah, that's what we've seen too. I'm gonna, excuse me, I'm gonna stop right there and open it up for our participants to get a chance to ask you what's on their minds. So Fadi, Fadi or Zaid, if you want to also maybe ask a question before we move on to participants.
That's okay. Anna, I have a couple of questions, but I can delay. We can start with one question from, I think, Muhammad Wajih. Did you find a relationship between race and severity of the disease, since we have a study ready to be published in Jordan about such issue?
Well, yes. So the race is complicated in the United States. If you look at where the cases are coming from in New York City, the majority tend to be from parts of Queens, parts of the Bronx. And those tend to be the areas where all the minorities live. In the Bronx, it's mostly Hispanic and Black population. And in Queens, it's also, there's a Bengali population, there's a big Pakistani population, there's also Hispanic and Black. And so but the problem also there is they tend to also be poorer, and if these people are living 4 or 5 people in a one-bedroom apartment. They tend to be the essential workers in the sense that they're running the supermarkets, they're running the delis, the back end of the restaurants. These people are still going to work. And so we are getting a lot of patients from that community. And the question is it because of race or is it because of socioeconomic factors? It's very hard to differentiate it. Once we see these patients, in the hospital, there seems to tend that the Hispanic and Black patients tend to do a little bit worse when you control for other factors. So the answer to why that is, I don't know. But that's the tendency at the moment, and I think it's worth waiting to see what bears out in the data afterwards, because it's, you need to control for the fact that these are the socioeconomic factors tend to also play a huge role and are associated with your race in, sadly, the United States. And I question back, if it's a study published in Jordan about Jordanian data, as he can type it.
محمد إذا بتحب تطلع off
Yeah, he wrote something about angiotensin converting enzyme 2. So angiotensin converting enzyme 2 is an enzyme that is found, that was found in the lungs and initially thought to be a big reason why the Asian populations did worse. And it's thought to alter the how bad the disease can manifest in someone. And I'm not sure, maybe he knows better, but I'm not sure that it's been borne out that this is exactly why some people do better, some people do it. And that enzyme is present in different populations at different levels. That's, I think, what he is, if everyone's looking at the chat, that he's right.
Cool. Zaid, I saw you have a question.
Yeah, I have a question for Dr. Hadi. It relates to your view on vaccines. We were chatting offline in the beginning.
Yeah.
How is that going? What's your views there? I mean,
Trump just said he's going to announce. Trump just said he's going to announce a major step forward in vaccines as we went into the Zoom meeting. So I'm not sure what he's going to say. Vaccines, it'll be great if there's a vaccine, but I don't think we can hold any hope. We should operate under the assumption that no vaccine is coming, and the reason that is because vaccines. The quickest vaccine, I forget if it's mumps or measles, took 4 years to develop a while ago. And by development is, they come up with candidates, they test them on people, they make sure the side effects aren't bad, and then they make sure that it works, and so on and so forth. That takes a very long time. You can't expect people to come up with that technology and prove that it's safe within the next few months. I think that's very, very unreasonable. I think a year and a half is would be a reasonable estimate if everything goes well, if you don't have side effects, if it works, and so on and so forth. And the reason I think that we shouldn't bank on a vaccine is because we'll end up waiting for a very long time before things start opening up. If that's the only thing that we are sort of hanging our hat on, I think that's risky because it may never come. There's no vaccine for herpes. There's no vaccine for HIV. There's multiple other viruses that don't have vaccines. So I'm not sure what makes us sure that, a vaccine is a given. So a vaccine may never come. And that would be very depressing. So I'm not so, obviously I would love a vaccine to come up and, but I'm not so sure that it will in the next, I think, 2 years.
Okay.
Plus if it does come up, sorry, back to Zaid or anyone here, just more of a rhetorical thing. Let's say they come up with a vaccine in the next 3 months. Is anyone on this Zoom call really willing to take it untested, untried? I think you need public buy-in big time into trusting that this vaccine, even, there's so much about these conspiracy theories and all that. Like, I'm sure you're going to get a large chunk of people who won't take it, even if it's produced.
Yeah. All right, Raghida وبعدين رائد. Raghida, go ahead.
Okay, can you hear me, guys? Okay.
Yes.
Okay, so first of all, thank you for all the things you do to keep us healthy and safe. Second thing, my question is related to the infected cases from the frontline people. How are you guys dealing with these cases? Do you have an isolating room for them? Or do you have specific spaces in the ICU for them? I know everybody's lives matter, but those cases, I believe like they have the priority, especially because they are, you know, they are in the middle of the bath.
So thank you for your question and thank you for the kind words. No, we don't have any special places for the doctors or the nurses or anyone who's been on the front line. And that's actually better for them. In medicine, it tends to be when you give people special treatment, you know, we joke that, you know, the special treatment actually tends to make things worse for people. You know, the nice floors on hospitals tend to be the top floor for the VIPs and all that. And we joke and we say that tends to be closer to heaven. That's why we put them there. You know, I say that facetiously, but it's bad medicine to treat anyone differently. So we treat everybody the same. The difficult part is when you see your colleague or a nurse or anyone sick, it's incredibly heartbreaking because you know that person. One, you work with that person. Number two, number three, that could have been you. And so it takes a huge toll on the morale of the people taking care of these people. But we don't give any special treatment or special rooms or special anything other than our special empathy, I guess, towards them.
Raed?
Yes, Dr. Halazun, thank you as well. This is Raed Samara. Maybe it's a comment and a question. Going back to Muhammad's question about the susceptibility of different races, having been sort of exposed to some of these studies, I don't think any conclusions can be made right now, simply because to establish susceptibility, you do need to have large number studies, and I don't think we're at that point yet. And the question is, so looking at what could happen in the next 6 months, right? Like if we fast forward to the next fall, have we learned enough now to be ready for, let's say, a scenario that could be much worse than what we're experiencing now? It could be much worse. It could be easier. It could be the same. But if it actually does get worse, are we better prepared, let's say, for the next fall than we are now?
Absolutely, we're absolutely better prepared, and I'll give you two examples of that. If you look at what happened in Italy, were caught completely off guard. They had no clue what was coming, and they had to get to a point where they were actually very limited in both supplies meaning ventilators and other medical supplies, and also staff. They were so short-staffed because they hadn't closed things fast enough. They hadn't gotten to the point where they thought, oh, we need to close all the elective stuff or all the surgeries and so on. So they got hammered on the front end of the pandemic. And we learned just watching them, even though some people may argue that we did not learn on a national level in the United States, at least. We learned that, we need to close these things. We need to make these adjustments before this comes. And we did. And that's why the immediate deaths and the immediate rush of patients was sort of dealt with in a much better way, sort of logistically than the Italians. Also, we now know so much more, even though not enough, about the virus and how to treat it. When I first started in March, the idea to give blood thinners as a therapy, we usually give blood thinners as a prophylaxis, meaning we give a small dose of blood thinners to patients in the hospitals to prevent blood clots. But we don't give a full dose to treat blood clots. But we've learned very quickly that many of these patients, that amount, the small amount of blood thinning is not enough. So, this disease is not just one of the lungs, it's one that can cause blood clots throughout the body. So we quickly learned to put the majority of our patients who are sick enough on blood thinning medications. So I use that as an example, is that, we are in a much better place, much better suited to treat whatever comes to us. But are we at the best place? No, I think that we can still learn more, and we will learn more. The other side of another additional thing, to answer your question, to deal with the next wave, or if more is to come, it depends on where you are in the country and the world. And I think that is assuming that there is some sort of immunity. If you have, I'm sure everyone's heard of the term herd immunity. If you're close to herd immunity in your community, then you're less likely to see a large second wave. But if you're not, then that second wave may be larger than the first wave. You know, to take Jordan as an example, the amount of people who have been exposed to the virus has been very, very low. They did an amazing job at preventing this first wave on completely overrunning the medical system. There's very few deaths relative to the population. Obviously, we're hearing of new cases pop up now, but they locked it down so severely in the beginning, and that's great. But now they are going to be stuck with the potential of their second wave being larger than their first wave, because there's not anyone who's immune, not anyone who's been exposed. Versus New York City, the data varies, but we think maybe 20 to 30% of people in New York City have been exposed and have antibodies. And so the likelihood of a second wave is very low, or at least as being as big as the first wave. So it really, what we've learned from logistics and medicine, we can apply everywhere, but are we prepared for what's coming next really depends on where you are in the world.
Thank you.
All right, so this is a good segue. Lana Shukum has a question, and ما بعرف إذا أنت already you answered it, Hadi. But can Hadi address the construct of herd immunity within the context of the US as well as Jordan? So ما بعرف إذا في أشياء ثانية بتحكيها.
So herd immunity, let's say بالدلوح. Let's say you have 1,000 people in a room or in a country, okay, and the virus can go from one person to 2 people, and then 2 people to 4, and then exponentially grow. Once you reach like 60%, that's the said number. Let's say 600 people are infected and develop the antibodies. It's hard for the virus to find someone who's not infected. And if you think of it as these dots in a room, the virus has to go around and very easily in the beginning infects a lot of people. But once 60% are infected, the virus has to look around for people who are not infected. And not only are there less people who are infected, who are not infected, but people who have been infected in the past can't pass it along. So if you have the antibody and you come into contact with someone who has COVID and is coughing and fever and all that, and they cough on you and you have the antibody, you won't get it, and plus you won't transmit it. And so it just reduces the number of people that one person who's coughing and has a fever can infect. But you don't need 100%. You can only, the virus will eventually kill itself by not being able to transfer from one person to the other. So the thought is, once you reach 60% of the population, that the virus can't go. There's a good, I'll send it to you, Fadi. There's a good simulation about herd immunity that sort of describes what I'm saying, if you want to distribute to the list later. But it's the best I can do right now. Is that clear? Sorry if it's not.
Lana, you're okay with the answer? You عندك follow on?
It's okay if you're not. I can try again.
Okay, I look forward to reading the article. Actually, I'm good.
Okay, sorry, bad explanation.
No, that's good. I can follow up.
Cool. مين كمان؟ في حدا عنده أسئلة؟
طب خليني أقول لك, try to explain again. I want to make sure that you need enough uninfected people for the virus to stay alive. And if you have people who have been infected in the past and have antibodies, once the virus enters their body, the virus is dead. And so if the virus needs to jump to someone who either who hasn't been infected, it's just going to find it much harder to get to that. It's going to have a very hard time getting to this uninfected person if they constitute the minority of people in the community. Does that make sense? That's how vaccines work. You don't need to vaccinate the 100% of people. You need to vaccinate enough people so that the virus has a hard time finding that susceptible host. Does that make sense now?
Yeah, no, it's good.
إذا ما حدا عنده سؤال أنا بدي أسأل سؤال.
اسألني.
سؤال صراحة حاولت أنا أعمل my own research عليه.
لا.
هلا ما زبط. سانجي غوبتا بأول ما بلش البانديميك كان بيحكي على موضوع الأكل إنه you can't get it from ingesting food ماشي which is I think scientifically correct. What I have hard time with إنه صار في كتير restrictions على المطاعم sure عشان الناس قاعدة جوا بس even عشان picking up الأكل. طب إذا الهايبوثيسيس إنه ما راح يجيك من الأكل then what is the real risk? Is the real risk أنا مثلا جبت تيك أوت والريسك من الباكجينج ولا الريسك من اللي جوا الباكج وهاو كان يعني أنا عم بفكر فيها لأنه بتجيب أكل من برا if you هيك شميته إذا بتشم ريحته can you get it from smelling it?
No.
طب أوكي
I think
وبعدين ليش
the portal of entry is through the respiratory tract and not the or sometimes people think maybe the eye and it is a portal, the eye is a portal of entry for other viruses but it's the respiratory tract and not the I understand you can ingest within the respiratory tract but I'm not صراحة I don't think it's transferred. We think of food-borne viruses as being just that, foodborne, and you eat them and you ingest them, they go through the GI tract. I think if I didn't ما فكرت إذا راح تاكل الأكل وعليه الفيروس ودخل I don't know the answer to be quite honest.
أنا سألت أنا أبوي is a pulmonologist فسألته هذا السؤال
قول لي هيك قبل ما تسألني
لا بس ما هو أنا هلا مش مقتنع يعني مش مقتنع ليش؟ لأنه something doesn't add up إذا ما في ريسك من الأكل طيب كثير في مطاعم سكرت فرضنا اوكي
المطاعم مسكره مش عشان فيش اكل كل مطاعم مفتوحه بنيويورك فور ديليفري it's their choice ما يعمل في عنا تبع مطاعم هون he can tell you it's not about the food is still safe to eat it's about the containers as you say and that's an extra precaution هو صراحه that شوي زودها يعني with that precaution but you need to be on the other end of taking precautions, but it's not in the food that you eat. It's not been shown. The pathophysiology of that, I don't know. But it's not been shown that the food is a vector. زي ما E. coli, the E. coli, if you have E. coli بالأكل, you get diarrhea, you get sick from it because it's a GI bacteria. It's not a virus.
وانا هلا بدي اخلي زيد يحكي لانه زيد هيز بزنس اوبريتور بس سؤالي قبل ما اعطيها زيد شو بنعرف عن الريليشن شيب بين المالتي سيستم انفلاماتوري سيندروم كوفيد
تبع الاولاد الصغار؟ اول شيء واهم شيء اللي عنده اولاد انه it's very rare. I think the it's making the news for two reasons. One, pediatric illnesses tend to be in the news much more so than adult illnesses. وزي ما شايفين الناس are ready to break quarantine for this. It's an adult illness. If this was purely a pediatric thing, no one would want to break quarantine. يحط أولاد at risk. So I think the first thing to know that it's very, very, very rare. The second thing is, I think ما بنعرف لسه. It's similar to Kawasaki's disease. Kawasaki is an inflammatory disease of the blood vessels and throughout the body, but mostly what kills these people is the inflammation of the heart and inflammation of the arteries of the heart, of the coronary arteries. What we've seen, the symptoms look similar to Kawasaki, but I think no one really knows exactly what is going on with that. I think the most important thing that gets lost in the media in how rare it is. No one wants kids to die. Oh, sorry. The other point I wanted to make إنه كل 3 أشهر أو شهرين ونص عم نحكي إنه هذا is an adult thing. Kids don't transmit it. Kids are fine. Kids are safe. وهلا we're saying wait, hold on. Maybe kids aren't safe. Maybe kids one, it's emotionally difficult to accept that a child's going to get sick. But two, it has socioeconomic implications. عشان the first thing, especially in the United States, to reopen and to put people back to work are the schools. You don't open the schools, people can't go back to work. And so the strategy has always been, since kids are safe, why don't we just open the schools, we'll send them to school, that way mom and dad can go to work, وبطل عنا قصة work from home عشان فيش daycare, and it really puts people back into the economy. But now with this, I think it's going to have very big implications on schools restarting. And so more and more people are going to be working from home, not to isolate, but because there's kids to take care of at home.
Yeah. زياد كان عندك إشي ما بعرف حسيتك بدك تسأل سؤال ولا؟
Yeah, I just wanna chime in on the restaurant piece. So the reason that the restaurants are not open for in-store dining is so that people don't congregate.
Yeah.
It's not really about the food, it's about the social distancing. And what's happening in San Francisco, which is really ironic, by the way, in downtown San Francisco, they did not allow retail to open or to have curbside pickup because there's so many retail shops. Individually, they're okay, but if you have all of them open, then you're gonna have people out droves. And that's why they did not allow retail. Now they're allowing them next week actually to start opening as pickup only. And what they're doing in San Francisco and a lot of the cities, I don't know about the rest of the nation, but in the Bay Area, there's people trying to close streets for cars and have tables for diners to eat in the streets, especially now that the weather is getting better. It's really all about social distancing. It's not about the food in terms of spreading the disease. That's the only thing I wanted to add. Thank you.
Okay, so في عنا a few questions. ما بعرف HP أو محمد بتحبوا تطلعوا على المايك تسألوا أسئلتكم، بس basically I'll start with محمد. Well, like there is a lot of talk about vitamin D and COVID. Why is it not in treatment protocol?
I'm not so sure it's been shown to do any difference. I think vitamin D, you know, if you follow vitamin D some people who swear by vitamin D, it can cure everything. And so we have to take anything that's said about vitamin D with a grain of salt. You know, there's a lot of, you know, nutritionists who whatever saying vitamin D for depression, vitamin D for anxiety, vitamin D to prevent cancer. So I'm not surprised that there is a lot of talk about vitamin D giving it. And for the most part, I'm not so sure that there's not much harm in taking it. So if you want to take it. But I don't think it's going to affect the way the virus works in your body.
Okay. السؤال الثاني بعدين رغيدة تطلعي على المايك unless HP بتحب تسأل سؤالك على المايك أو بتحبي تسأل سؤالك على المايك. If not, I can read it. If a person suffers from psoriasis and the immune system defect is in the TNF alpha protein, could the biological treatment for psoriasis support the immune system against COVID, or might it be counterproductive? What are physicians' subspecialty best to manage a patient with this health profile?
I would say the best specialty is either rheumatologists to talk to them about that. I'm not so sure I have the answer for that, but we know that, and if this person has psoriasis and is on a TNF-alpha inhibitor, which is an immune modulator, it may put them at risk because they're immunocompromised makes them more susceptible to the disease. Those are one of the underlying conditions, so to speak. But I don't know I would talk to a rheumatologist about that. I honestly don't know the answer to that question.
Thank you. Raghida?
Okay, so on the windy days, does the wind increase the chances for the virus to be spread out between the people?
شوفي it's a good question, and you know I'm not joking about it, but because Donald Trump was on an interview and he spoke with some soldiers on the World War II memorial or whatever it is, and he wasn't wearing a mask, and the guy was one of the last survivors of the war. He was 90-something years old, and Trump's excuse for not wearing a mask with this 90-year-old guy is that the wind was blowing in his face and not in the other direction. Now, is there credence to what he was saying? No, because the virus can go in both ways. The wind's not going to push it away, and if you have the virus and you're talking to me and the wind is blowing against me, the virus can still travel forward. Now, does it travel less forward or not? I'm not sure, but I don't think standing in the correct direction of wind would be a good way to protect yourself from it.
شكلك بتحب السياسة كمان هادي، خلينا نحكي.
احكي بالسياسة، ايش ما بدك. بس هذا مسجل.
في حدا تاني عنده أسئلة؟ Anyone? Last call? We are almost at the top of the hour.
We're at the top of the hour. I think we're good. If I may just say one thing, since we're wrapping up. Thank you so much, Hadi, for your time. Thank you for everything that you're doing, and take care of yourself and your family. And keep in touch. We would love for more conversations in the future. Hopefully, we'll have better news moving forward. But if you have one last thought to share with us here that other listeners would pick up on how we can sort of manage this as we're trying to, from a doctor at the front line, like what would you say?
So I think the first thing is to know is that we're all in this together. I know that sounds like a political blah, that we're all in together, but it really makes a difference to think that, I know it sucks to sit at home, Marissa, and you know where to go, but no one's going anywhere. Everyone is in it together. Similarly, in the hospital on the front line, we're all in it together. We all have this one goal, and actually, there's a beauty in that. So I think there are, other than meeting people with Zoom on the silver lining, I think the message I would leave is that I think this is a very good time to really reevaluate what you actually needed, who you actually wanted to be with in your life, and when things are open, who do you want to see and who do you want to talk to and who do you want to be around? And I think that is having a hopeful look as opposed to a fearful look towards this is the way I'm managing it. And honestly, a big way in doing so is really avoiding the media. And it's if you're watching the news, inevitably you're going to be anxious. Nothing is going to change between today and a week from now in your life. Absolutely nothing. If you don't watch the news, except when I'm on, you can watch the news.
Tell us when you're on.
If you don't watch the news, your life will be much, much simpler. And I think from a health perspective, I think, as a doctor, I can't not say this, and it's obvious, but I think it's particularly important for now. We're moving less, we're walking less, we're exercising less. Don't let that happen. Exercise at home. There's tons of YouTube exercise programs. There's tons of things to go for people with nice weather outside. Exercise as much as you can. Try to get in shape, only because the underlying, and I don't want to scare you, but the underlying conditions that they talk about on the media. One of them, for example, is being overweight, and they don't. And we see that. I see it, and there's people who are completely normal, just happen to be overweight, and they do poorly. And so, if that's not a motivator, I'm not sure what would be. So that's my 2 cents.
Cool.
Great, thank you. Great last thoughts.
Speaking of the people that we love, I can't wait to go back to Amman وأشوف أهلي.
يعني أنا أهلي أظني one of the toughest things for me, and I didn't mention it, sorry, this one last thought. I have a son who's 7 months old. I'm not sure when my parents are going to see him and hold him. We do FaceTime, but it's not the same. Marissa's daughter was born one day ahead of my son,
apart.
and has developed milestones much more than my son. And we're catching him up. And I can't imagine you're going through the same thing, Marissa.
Yeah. But I hope that we'll just like you said the other day on the phone. It's harder for the grandparents than for the children. The children are very adaptive, and I'm sure they're digital natives at this point. But they will learn, and I hope that we'll have an opportunity to all see each other in person, and definitely our families first. But thank you so much.
My pleasure.
Yeah, this was wonderful.
Happy to do it again if you ever want me back.
Thank you, and thanks for everyone who joined us today as well.
Yes, all of us.
Have a nice weekend.
Great.
Thank you, guys.
Thank you. Thanks, Hadi.
Bye.
Take care.
Thanks, guys.
Bye-bye.
Bye.
Bye.